Hi, my name is Kathleen Donlinger, and I am doing my assessment scenario regarding a 56-year-old currently admitted to my floor, status post TPA, for a right MCA ischemic stroke 3 days ago. He had put on the call light complaining of an 8 out of 10 headache, and I note that the patient's left grip is much weaker than the baseline when he tried to hand me his water pitcher. The patient's past medical history includes diverticulosis for the past 4 years, occasional lower back pain controlled with over-the-counter NSAIDs, a history of tension headaches and atrial fibrillation. His current medications include metoprolol, 25 milligrams twice a day, Xarelto, 20 milligrams once a day, pantoprazole, 20 milligrams once a day, and he has lactated ringers on his left antecubital IV, peripheral IV, and it is hanging at a rate just to keep the line open, so I'm assuming about only 75 to 100 milliliters per hour max. Questions are being asked to help me guide my actions or thinking actions today are going to be: what are my next actions? Why? What would I assess and why? What are my thoughts on what is happening? What do I think the patient got to this point? And are there labs or diagnostic tests I would recommend, as well as medications are appropriate, and what would I be adding? Looking at this patient's situation, with the patient's history of an ischemic stroke and AFib, I would want to make sure that they're not having another stroke right now. Even though we did give them TPA, once you have a stroke, you're at an increased risk for another occurrence, especially more recently after that first occurrence of stroke. And also, because of his atrial fibrillation, the stasis in his left or both right atriums would increase his risk for clots to be thrown from the AFib if it's been uncontrolled, or if we've changed anything just from the stresses of being in the hospital as well. However, since this patient was also given TPA, I would also now be concerned for a hemorrhagic stroke. First thing in my mind is I want a CT as quickly as possible to see if it is ischemic or hemorrhagic, so I can treat this accordingly. I would need to intervene with calling the doctor to get an order for the CT, giving SBAR my recommendation of that, and I would ask to intervene with internal or with radiology to make sure we get that CT as soon as possible, or stat. With this patient's past medical history, the diverticulosis for the past 4 years puts him at an increased risk for bleeding as well. I would want to assess his labs most recently and nutritional status. I would want to trend those labs, just making sure that we haven't been missing another bleed, so I'd want to see what his H&H has been looking like. If it's been decreasing, I'd want to be looking at his electrolyte status, things along those lines. I would also want to maybe look at his CRP and sedimentation, ESR sedimentation rate, to make sure that we have that inflammation under control, especially just because of the stresses from his stroke diagnosis. I would want to assess bowel sounds, or just kind of check in the charting or with report, just to see what was been going on with his bowel movements and what kind of deficit he's dealing with as far as the stroke. With his occasional lower back pain, the mention of the controlling with over-the-counter NSAIDs, that just tells me he's again at an increased risk for bleeding. So that concerns me with the diverticulosis, the bleeding, the TPA, and the NSAID use. That all to me now says, well, did we give him the TPA? Now we're dealing with the bleed. With the tension headache, if he has a history of tension headaches, is what he's experiencing right now the 8 out of 10 headache just a tension headache? So I would want to assess this patient's pain. What does this pain feel like to you? When did it come on? What does the pain, if you can describe it, is there a certain area? Have you felt this type of pain before? Does this feel like one of your tension headaches, or is it something different? And I think depending on what the patient tells me would also direct which path I go down regarding what he's feeling. With the atrial fibrillation history, I know, again, as I mentioned, he's at increased risk for clotting. Has this been a problem for him for a while? Has it been well managed? Has he been taking medications? I want to make sure this patient's on cardiac monitoring, so I would also probably want to run a quick EKG if we can, or we can get an order for a 12 lead just to see what's going on there if he's not already on a monitor. The medications to me seem appropriate: the metoprolol, the Xarelto, the pantoprazole. Metoprolol is it's a beta blocker, so we're dealing with his heart rate, especially with that AFib. The Xarelto is for his clotting, so is it appropriate? Sure, but I'd be concerned with that because of the TPA administration. I would almost just But if I had to question any medication, it would be the Xarelto that I question. I would ask if perhaps we could stop that Xarelto, just because I think it takes longer to get out of a patient's system. It has a longer half-life. And I think that, if we have to, maybe we want to look at something such as a Lovenox shot if we absolutely have to, because again, with the TPA, we're worrying about bleeding with his history of clotting and his disorders for bleeding and being the diverticulosis, but also the AFib. It's kind of a balance here now with the bleeding, clotting. We need to find out what's going on. So again, we're looking at labs, platelets, things like that. The lactated ringers to keep the line open. There's no reason we can't be better hydrating this patient in my mind. I might want to up those IV fluid orders and see if we can maybe increase them a little bit. As long as he doesn't have any cardiac damage and we're not worried about any fluid volume overload, I would just want to keep him better hydrated, especially with his clotting status, venous stasis. I just want things healing and flowing nicely. But again, as long as there's no fluid volume overload risk for him with any comorbidities or histories on that, I would just monitor for like lung sounds, edema, things like that. Being that I am thinking that we're worried about hemorrhagic now, I would also want to keep this patient NPO. I know that we may also have to do surgery to evacuate the bleed or the hemorrhage if that is confirmed by CT. So again, if he's going to be on NPO, we might as well up those fluids. Again, so next action, I want to do a focused neuro assessment and call the doctor for SBAR for findings. I want to do labs and CT are my biggest thing. Like, what is this? According to what my patient says and according to what my neuro assessment tells me, I'm going to be asking questions about that headache. Like I said, like, when did this pain start? Does anything make it better or worse? Are you sensitive to light? Does it feel like your tension headaches? Or, is this something else where we're having that weakness that I noticed? Due to his increased weakness, I want to, have a pen light handy. I want to do a pupil assessment. I want to do some grips, pushes, pulls, bilaterally, maybe do some facial expressions to assess cranial nerves. I'm not sure, as far as my learning so far, what the protocol for TPA is post-administration. I know pre-administration there's a huge protocol list for TPA, but I'm not sure how TPA works afterwards. So again, depending on how that goes with my research, for further knowledge, that would help me better determine if this was perhaps another hemorrhagic or ischemic stroke. I also, not high on the priority list, but I also just want to consider too, are we doing DVT and PE prophylaxis? Are we dealing with his PT-OT status? What is his baseline for these? I know that rehabilitation is key for stroke patients, so do we need to worry about further deficit? Most definitely. Other labs, maybe can we do a D-dimer or other clotting tests? Can we look at, again, his platelets and see what they've been doing as far as trending? I really want to know what they've been doing trending for his blood labs. If we rule out a stroke, ultimately hemorrhagic or ischemic, and this is in fact just a tension headache or perhaps just dealing with his stress of being in the hospital, obviously I'd want to be giving something for the pain. And again, because of the deficit, I probably want to get that pretty well managed, not really with something like an NSAID in my mind, probably more morphine or something along those lines. I probably went over my time, but I do thank you for listening to my critical thinking skills for this assessment scenario, and I hope I've hit the marks. Thank you. Have a good day.